Hello, my name is Marcy Lee, and we are going to review Meaningful Use 2015 per the CMS revision to the final rule that was released on October 6, 2015. When we are finished today, you should know the following. You should know what the reporting periods are. You should understand the amended meaningful use requirements, understand the exclusions, know the attestation dates, understand penalties for non-participation, and we will cover a brief overview of Stage 3. In 2015, the reporting period is 90 days. It must be a continuous 90-day period. It does not need to be a calendar quarter, and this is applicable for Stage 1 and Stage 2 providers. I just want to go over a few facts before we dig into the actual changes and the details of the new objectives. So first and foremost, good news, the amended rules should make it easier for all providers to obtain meaningful use. I also want to point out that the clinical quality measures, or the CQM reporting requirements, have not changed. They have remained the same. Also want to just remind everyone that a 2-year look-back is used for the Meaningful Use Program. This is not a change, but it's important to understand that what you do in 2015, you will not be rewarded or penalized for until January 1st, 2017. So CMS has been using this 2-year look-back, and they will continue to use the 2-year look-back. I also like to point out that previously, when we thought of meaningful use, we thought of the core, the menu, and the clinical quality measures. So we kind of had meaningful use broken down into 3 different groups, if you will. Now that core and menu set is gone. It's been replaced with a single set of 10 objectives. So now when we think of meaningful use, you want to think of the 10 objectives and the clinical quality measures. Since the amended rules for 2015 have been released on October the 6th, CMS now had to go to work to create an attestation system for all the providers to use. So the first day that that attestation system is available is January 4th, 2016. The last day the attestation system is available is February 29th, 2016. With that being said, it would be a good idea to try to get your attestation taken care of in January or the beginning of February. That's a small window of time for all the providers in the United States to get their attestation completed. Okay, here are the 10 objectives. I'm not going to read over these objectives. I'll just give you a moment to look down the list of them. Remember, as I previously said, these 10 objectives have replaced the core and the menu set measures. What we're going to do moving forward is look at each one of these objectives in detail so you understand them much better. Okay, objective number 1, clinical decision support. If you are a Stage 2 provider or have a Stage 2 provider, there's really not a big change to this particular objective. You must implement 5 clinical decision support roles, and you have to make sure that you've enabled and implemented the drug-to-drug and drug-to-allergy checks for the entire reporting period. If you are a Stage 1 provider, you only need to implement 1 clinical decision support rule. There are no exemptions to this clinical decision support objective, and it is important to realize when you create these decision support rules, they do need to be linked to your clinical quality measures and or high priority health items that are high priority items to your individual providers. Okay, objective 2, protect electronic health information. This remains unchanged. This is the one item that has remained the same since the beginning of the Meaningful Use Program, so I'm really not going to expand on this. It's the same for Stage 1 and Stage 2 providers, and this is something that you are expected to take care of every year. No exemptions. Computerized provider order entry, or we also call it CPOE. If you're stage 2, these percentages look the same. 60% or more of your medication orders need to be entered into the EHR. Greater than 30% of lab and radiology orders need to be entered into the EHR. So this might not look like it's changed much, but I want to point out that you no longer have to take a lab or a radiology order and follow it all the way through, meaning order it, then make sure that it's accessible in the EHR, and then click the reviewed to show that you've actually followed it full circle. So per meaningful use, it is no longer necessary to follow it all the way through to meet meaningful use. Now, for stage 2 providers, there are exemptions. So when you go to a test for the CPOE stage 2 providers, you're going to basically attest to A, B, and C. Each one of these is looked at individually. You can take an exemption from one of these if, for example, the medications, you write less than 100 medication orders during the 90-day period. You could take an exemption from that. If you write less than 100 laboratory orders during the 90-day attestation period, you can take an exemption for that. And if you write less than 100 radiology orders during the 90-day attestation period, you could take an exemption for that. So you have to basically look at each one of these individually and decide if an exemption is going to be applicable for you or not. If you are a stage 1 provider, the only criteria for meaningful use is that you have to enter greater than 30% of the medication orders that you create in the EHR. Stage 1 providers do not need to worry about lab or radiology orders being entered in the EHR. E-prescribing. This is pretty much the same as it previously was. You need to make sure that more than 50% of your prescriptions are being sent electronically and queried for drug formulary. Again, the exemption is if you have a provider or if you are a provider who writes less than 100 prescriptions during the EHR reporting period, or if there are not any pharmacies that are located within 10 miles of your practice. If you're a stage 1 provider, you simply need to electronically prescribe greater than 40% of your medications. There are no exemptions. Okay, health information exchange. For this particular measure, you need to generate and transmit a transition of care electronically for more than 10% of your referrals and transitions. So this is really a two-part. You need to generate a TOC, as I call it, a transition of care document, and you need to transmit that electronically. So in order to transmit the information electronically, you will need to be using direct messaging. If your direct messaging is not turned on in your EHR, then you can contact support, or you can go onto the STI website under enrollments and complete an enrollment for the direct messaging, and that will be turned on. You are eligible to have direct messaging as long as you have a provider who is e-prescribing. Now, the exemption for stage 2 for this objective is that if you do not transfer if you transfer, less than 100 times during the EHR reporting period, so less than 100 referrals or transitions during the reporting period, you can take an exemption. A lot of specialists are probably going to be eligible for the exemption for 2015. However, if you do indeed refer more than 100 times during the 90-day period, you do need to make sure that you meet this particular measure. For stage 1, it's not an applicable measure, so you don't need to worry about this particular objective if you are a stage 1 provider. Patient-specific education pretty much remains unchanged. You just need to make sure that greater than 10% of all your unique patients who have been in during the reporting period are given patient-specific education materials. The only exemption would be if you have 0 office visits during the reporting period, or if you're a stage 1 provider, this was optional. You had different options that you could choose from, and if this wasn't something that you previously intended on reporting on, you can take an exclusion for that reason. Medication reconciliation. Again, this pretty much remains unchanged. You need to make sure that more than 50% of your transitions of care in which someone's coming into your care have the medication reconciliation completed. Continue to use that medication reconciliation button that you have in your EHR, or continue to indicate using the CPT code that you've done a medication reconciliation so that you will meet this for greater than 50% of the transitions of care. And the exemption for stage 2 providers is if you are not the recipient of any transitions during the reporting period. However, I'm going to say not many people are going to qualify for this exemption because every provider is going to have at least 1, 2, or 3 patients who have been elsewhere since they previously saw you. So if they've been to a medical aid, they've been to another doctor, or any place at all that involves their health care, you do need to make sure that you're taking care of that medication reconciliation when you see the patient back. And for stage 1, this is not an applicable measure. Okay, patient electronic access is the next objective. We also call this VDT, or the View, Download, Transmit objective. This is referring back to the patient portal, so you must have the patient portal. And if you are a stage 2 provider, you just need to make sure that you have 1 patient that is seen by you during the reporting period or discharged from the hospital, view, download, and transmit their health information. So this is good news. Previously, this measure had to be at a 5% or greater threshold. Now, just 1 patient needs to have viewed, downloaded, or transmitted their information during the 90-day attestation period that was seen in the office or that was discharged from the hospital. And the second part to this measure is that greater than 50% of all the patients that you see during the reporting period are invited to use the patient portal. Now, there's really, with all the changes that have been made to the software, there's really no reason why that part 2 of this particular objective can't be at 100%. So that 50% threshold is very simple to meet. Even if a patient does not have an email address, you can go in with the changes that we've made in the software, and you can invite them to join the portal, print out the document, and hand to the patient, which instructs them, if they choose to set up an email in the future, what steps they would have to take to engage in the portal. So let's just review for stage 2. This VDT objective, you have to have 1 patient view, download, and transmit their information during the attestation period, and you need to invite more than 50% of your unique patients during the attestation period to join the portal. Now, the exemption for this particular objective is if more than 50% of your patients live in a really rural area, and there's more details out there if you believe that this is something that is pertinent for your office to get the exemption, you can go out to the CMS site and read in detail the exemption. If you are a stage 1 provider, you only need to have invited greater than 50% of the unique patients you've seen during the attestation period to join the patient portal. So you don't actually need anyone to view, download, or transmit their information. You just need to invite the patients to join the portal. Okay, secure messaging. This, again, still is needing the patient portal for you to complete this particular objective for secure messaging. So basically, Another good change, we don't need to have that 5% threshold anymore. We simply need to have the messaging functionality enabled during the reporting period. If you have the patient portal, you have the messaging functionality enabled. When you go to a test, this will be a yes or a no answer. So you no longer will need the numbers and you no longer have to hit a 5% threshold to meet this objective. The exemption, again, is if you believe that you are in a very rural area. For stage 1, this is not an applicable measure, so you need not be concerned with it. Okay, the 10th objective is the public health reporting. If you are a stage 2 provider, you must meet 2 of the 3 measures. When I talk about the measures, I'm referring to the Immunization Registry, syndromic surveillance reporting, and specialized registry reporting. For measure 1, Immunization Registry, if you give any immunizations at all during the calendar year, you need to be getting set up with your state immunization registry. If you are not already successfully and actively engaging, meaning it has to be an ongoing engagement, not, oh, I was set up for this, I automatically get credit. You have to be set up and you have to continue to submit the information to the state. If you have not already enrolled, please go out to the STI website, to the enrollment section, and complete an enrollment to get set up for the immunization registry. Should you have questions, you may contact clinical support for guidance. Now, if you don't give immunizations, you will be exempt from the immunization measure. Or if for some reason the state that you are in is not ready to accept immunization information, then you will also receive an exemption. I will tell you, most states are already set up and ready and willing to receive your immunization data. So please do not assume that your state is not ready. Okay, moving on. Measure 2 within this public health reporting objective, the syndromic surveillance reporting. You have to be in active engagement with your public health agency to submit this information. So right now, some offices might be calling in syndromic surveillance, faxing that information in, or mailing it into their state. You need to attempt to get set up to electronically send this information. Some states are ready, some states are not. In order to find out if your state is ready to accept syndromic surveillance, you'll want to go out to the Department of Health and Social Services website for your state. You can put within their little search bar syndromic surveillance or EHR or meaningful use or something like that. It will get you out to the proper section of their website and show you whether or not they are ready to accept syndromic surveillance. Keep in mind, some states are not ready. Some states are only accepting syndromic surveillance from hospitals at this point, and they're not accepting syndromic surveillance from individual providers. But you want to do that research on your own. Make sure you save screenshots if you're going to take an exemption because you're going to say your state wasn't ready. Get a screenshot with the date and time down in the bottom right-hand corner, or get something in writing that shows that at the time that you were attempting, it was not an option. Okay, moving on to measure number 3, specialized registry reporting. Again, the key is active engagement. You need to make sure, even if you were submitting information at one point and you no longer are, that you pick back up and you get an active engagement with a specialized registry. STI has partnered with CE City, and that's capital C, capital E, space CITY. So we've partnered with CE City just to make sure that we have an option for you to sign up for a specialized registry. If you want to sign up for the specialized registry, again, you need to do that through STI's website. You go out under enrollments, and you'll see the CE City enrollment, and we will then assist you with the process of making sure that your specialized registry is getting set up. And if you have questions about that, feel free to call support. Now, with the specialized registry, people always ask, well, what information will I be submitting? Well, it just depends on what registry you sign up with. You do need to make sure that it's a certified registry, and I put in parentheses at the end of the specialized registry, transition of care information, or the TOC information, is typically the data that gets sent out to these registries. So examples of some of that information would be diagnosis codes, payer information, procedure codes, medications, vitals, and things of that nature. Now, with CE City, you could either, they have a Genesis registry, which is just, it takes some pretty general information and gathers that information and submits for you. They also have other specialized options. So you can choose what you would like for the specialized registry reporting. In order to get an exemption from the specialized registry, it says you have to be a provider that doesn't diagnose or treat conditions that are associated with the specialized registry. And I'm going to say that I think this is going to be a pretty tough exemption to prove, because I can tell you that the Genesis registry will take any information. So even though they list an exemption for the specialized registries, I'm going to say you must get signed up with a specialized registry in order to meet meaningful use for 2015 and 2016. Remember, as a reminder, I'm just going to jump back a second, Stage 2 providers have to meet 2 of the 3 public health reporting objectives. Taking an exclusion from one does not mean, oh, I took an exclusion, so I tried to meet it, but it was excluded. You then have to try to meet another objective within there. Okay, now also, look at the red circle here at the bottom of the screen. It's important that providers be enrolled within the first 60 days of the 90-day attestation period that you choose. So, if you're reporting for the last 90 days of 2015, you need to make sure that you have signed up for the Immunization Registry, the syndromic surveillance data, or the specialized registry before December 1st. Now, the likelihood of you actually having successful ongoing submissions by that point is not very likely at all. However, you just need to have initiated. So as long as you fill out the forms before December 1st, you keep proof of that information that you've worked and you're trying to get set up, you should be fine. But it must be within the first 60 days of the 90-day attestation period. Also keep in mind that everything that we're talking about, these amended objectives, are not only for the remainder of 2015, but they apply for all of 2016. Okay, so that is the 10 objectives that now make up the meaningful use requirements. What I'd like to look at now are what is not really applicable any longer, or what significantly changed. So remember, when we talk about this, I'm saying that these are not required per meaningful use. Some of this data may be very necessary for your providers or for other government programs that you participate in. However, I'm only saying that they're not applicable to meet meaningful use at this point. So you no longer need to record patient demographics, the race, ethnicity, and preferred language. You no longer need to record vitals or get the patient's smoking status. That clinical summary, which is the number 4 bullet here, should make everyone happy. You no longer need to be handing your patient a clinical summary as they leave your office. You no longer need to export the clinical summaries and save those if you were doing that at the end of the day or after each patient left. So clinical summaries are no longer a factor for meaningful use. And the 5th bullet here says incorporate clinical lab test results. Remember, we spoke earlier that you need to enter 30% of the labs that you order for a patient into the EHR. You only need to enter it. You no longer need to pull the lab results into the EHR and make it accessible to the patient, and then also indicate that you've reviewed it. So they've kind of scaled that back. You're not going to need to generate a patient list at attestation. Patient recalls and reminders are no longer applicable, and these next two pretty much go together. We don't need to worry about the successful electronic exchange or the test with the CMS test tool. Also, secure messaging from patients, there's no longer a threshold for it. It just needs to be enabled for the reporting period. They took away the record electronic notes in a patient chart measure. And again, imaging results and information no longer need to be accessible to the patient and reviewed. You simply need to enter greater than 30% of your orders into the EHR, and you no longer need to record the patient's family history in that structured format. Okay, I want to review what stage 1 providers are required to do to meet meaningful use. Part of the reason why I wanted to put this together and kind of give you a snapshot is if you have providers in your office who are just out of med school, who are nearing retirement, or who didn't want to be bothered with meaningful use previously because they thought it would be too time-consuming or too cumbersome, I encourage you to have them revisit to see, now that these changes have come out, if it's more obtainable for them and if it's something that they might want to take advantage of. I certainly don't like to think that anyone who has access to a certified EHR like ChartMaker would not meet at least stage 1 meaningful use in 2015 and 16 because it really is very straightforward. So here are the required objectives for stage 1 providers. Let's talk about the reporting periods. We already said in 2015, it's any continuous 90-day period. In 2016, all returning participants are going to have to report the entire calendar year. And remember, that's the same data that we just went over. That's what you're going to have to do the entire calendar year for 2016. If you have a provider who is a first-time participant in 2016, they can pick a 90-day continuous reporting period. Now in 2017, again, all returning participants are going to have to report for the entire calendar year. The exception to that would be first-time participants can, again, pick any continuous 90-day period. And if you are a provider who is scheduled to be a stage 1 or a stage 2 provider in 2017, and you want to step up and say, I will try stage 3 in 2017, they will allow you to use a 90-day reporting period. Looking at 2018, all providers are going to have to report for the entire calendar year. Only exception in 2018 is going to be first-time Medicaid participants. So in 2018, it's important to know this. Everyone is 1 year, and there's no longer in 2018 going to be a stage 1 or a stage 2. Starting January 1st, 2018, every provider is going to have to meet stage 3, meaningful use. Okay, let's look at the payment adjustments for Medicare providers. Notice there are 2 different scales here of payment adjustments. So the top scale or chart, if you will, is assuming that less than 75% of all of the providers in the United States who are eligible for meaningful use actually are meaningful users. So if we have a performance rate of less than 75% of all users, eligible providers in the U.S. that are meaningful users, then it's going to be that higher adjustment scale per meaningful use. If we can get greater than 75% of all the eligible professionals in the United States to be meaningful users, it'll be a lower payment adjustment, and it will follow the second chart below. So we don't know at this point exactly what what the payment adjustments will be per meaningful use. It's just going to depend on total participation across the United States. Now, something else that has been modified, I should say, is pretty much at this point, meaningful use is looking from year to year to determine what the provider's penalty will be with this program. So, if you successfully participate 1 year, you can erase or eliminate your existing penalty for that year. Let's talk about an example just to make sure that this is really clear for you. So, in, say January 1st, 2019, they're looking for Dr. Smith, okay? So they're figuring out what Dr. Smith's pay is going to be for 2019. Medicare is going to do the 2-year look back, so they're going to jump back to 2017 and say, in 2017, was Dr. Smith a meaningful user? If the answer to that is yes, then Dr. Smith is going to be eligible for a 0% adjustment for his Medicare payments January 1st, 2019. So basically, there will not be a meaningful use penalty January 1st, 2019 because Dr. Smith participated successfully in 2017. However, if they look back and Dr. Smith did not participate successfully in 2017, then they're only going to be paying out at 95% of the allowable Medicare payments according to the top scale, or on the bottom scale, if we have most providers meeting meaningful use, then Dr. Smith would get paid 97% of the allowables. So you can participate and eliminate an existing penalty, but year by year, you'll have to make the choice whether you're going to participate with meaningful use or not to avoid any adjustments. Okay, we talked at the beginning that the attestation period is going to be pretty short since CMS is just getting the attestation system created. You should be preparing for attestation now. Here are places that you should be going to make sure that you know your logins, test your logins, test your passwords. Please go out and carefully review the information associated with each provider's login. Make sure the NPI numbers are correct, make sure the mailing addresses are correct, and more important than anything else, please check to make sure the email addresses are all up to date. Do not have emails going to a former employee of the practice, a former provider at the practice. This is how CMS primarily corresponds with offices regarding meaningful uses email. And if that email is going to someone who's no longer with your office, they're not going to take that as an excuse of a reason why you didn't return information to them. So please make sure that all information is up to date. Make sure you know the logins and passwords. Here are the places that you should be going. Also keep in mind that I tell you to do this now for another reason. If you don't know what the logins and passwords are and you need to get those reset, that could take days or weeks to have done. So when you go to a test, if you wait until February and then you need something reset and it can't be reset before the end of the attestation period, CMS will not use that as an excuse for an extension for the meaningful use attestation. So please go out here, check all of your information. Here are the phone numbers and the sites if you need assistance. I want to go over just a couple Medicaid highlights so that you understand the difference between Medicare meaningful use and Medicaid meaningful use. Remember that Medicaid is administered voluntarily by states and territories. Medicaid's going to pay incentives through 2021, and if you're in the Medicaid program, the professionals can participate for 6 years. Those 6 years in the Medicaid program don't have to be consecutive years. Looking at the second bullet point here, the last year that a provider can begin participation in the Medicaid program is 2016. And also keep in mind that the Medicaid incentive payments total $63,750 over 6 years, so it's substantially more than the 40-some thousand that the Medicare program paid. You can only participate in Medicaid or Medicare. You can't participate in both simultaneously. If you would like to make a change from Medicare Meaningful Use Program over to Medicaid Meaningful Use Program, every provider can do that basically once in the lifetime of their NPI. You can change from one program, one Meaningful Use Program to the other. Once you've made that change one time, regardless of whether you're going from CAID to CARE or from Medicare to Medicaid, once you do it once, you can no longer change again. Now, looking at the third bullet point here, it's important to understand eligible professionals can receive an incentive payment for adopting, implementing, or upgrading their Medicaid EHR. The reason that that's important is because as a first-year participant, professionals can get 2 payments in the same calendar year by adopting and implementing or upgrading within the same calendar year. So I always just like to point that out. Okay, now finally, I'd like to take a look at Stage 3 and give you a glimpse of what's coming our way for Stage 3. Remember, if you are willing in 2017 to try Stage 3 and you are only scheduled to be Stage 1 or Stage 2, they're going to allow a 90-day reporting period for you. Stage 3 is optional in 2017. However, as I said earlier, I'm just touching on this again, there will no longer be Stage 1 or Stage 2 come January 1st, 2018. As of January 1st, 2018, all providers must comply with Stage 3 meaningful use. Stage 3 is only going to have 8 objectives. So we're going from 10 objectives down to 8 objectives, which is good news. Here are the 8 objectives that we are going to have for Stage 3. And I don't have all of the details for these 8 objectives. It's still in review right now. As these 8 objectives are drilled down and they decide exactly what each objective will look like, we will, of course, post links out to the CMS site from our STI site, or you can go directly out to CMS and see what the details of this will be. I'd like you to just keep in mind that what they're trying to accomplish by amending the 2015-2016 meaningful use and amending the Stage 3 criteria is they're trying to get back into the original spirit of meaningful use, which is interoperability, improving patient communication, and improving patient access to their health information and allowing the patients to be more of their own advocates in their health care. So most of this information, or most of these 8 objectives, are in the spirit of the original meaningful use objectives. Okay, so that wraps up what I have for you today, and I thank you for taking the time to listen.